Give us a go ahead.
Sure.
Good evening, all of you. Welcome to this 275th edition of Thursday Musings. Uh, Today, we are talking about accessible and destigmatized addiction treatment in general hospital settings. We'll be recording this session. The recording will be available on the YouTube channel. Everyone is on the mute mode. Uh, the questions are invited in the chat box. So you have to type and send the question to us. This will be taken up to the resource person. Next slide, please. My pleasure in handing over the session to the chairman of this program, Professor Dr. Tufan Pati, sir. Sir, over to you. Please.
Thank you, Dr. Alim.
Yes.
Thank you very much. Good evening, everybody. Now, I have the pleasure to formally introduce our vibrant moderators, Dr. Alim Siddiqui. Dr. Please roll on the slides there. Dr. Amrit Pattidosi, Dr. Shobit Garg, and Dr. Vishal Chavra. All are there, vibrating as always. Next slide, please. I have the honor to introduce our chairperson for this webinar, Dr. Mahesh Kumar Suttar, Assistant Professor in Department of Psychiatry in Medical College, Baroda, Nodal Officer in Addiction Treatment Center in SSG Hospital with Medical College, Baroda, clinical experience of 16 years with 7 publications, Life Fellow of IPS in Addiction Psychiatry Society of India, area of interest addiction disorders, psychopharmacology and psychotherapy. Welcome, Dr. Suttar. Next slide, please. Next slide, please. Dr. Venkatalakshmi Narasimha, I think I am correctly pronouncing. MD PDF DM in Addiction Psychiatry 2020 Nemans Bangalore. ISM certification in Addiction Medicine 2019, ISM Canada. Current affiliation Assistant Professor Center for Addiction Medicine Nemans. Publications and research total publications 74. H index and total Google Scholar citations 14 and 985. Funded projects salient ones WHO, CIRO, ICMR, Vital Statistics. Awards salient ones below. Best Researcher Award 2023, AIMS Deogar, and Best Research Grant Award 2023, AIMS Deogar. ISM NIDA Fellowship 2019, DST Travel Grant 27, and World Psychiatric Association Travel Grant 27 to Bali. Fellowships for Dr. Ramachandra N. Murthy Foundation for Early Career Psychiatrist 2018, Professor Namman Seturias. Inne Bria Scholarship 2020, and welcome Dr. Narasimha. With this, I hand over the meeting to the chairpersons, and the CV of the speaker will be displayed. I think one of the speakers will introduce the speaker, and both of you will introduce the topic. Over to the chairpersons. Please take over.
Thank you, sir.
Please introduce the speaker, Dr.
Sure, sir.
Raghav.
So it's a pleasure to introduce Dr. Raghav, who is one of my good friends. I know him from the time he has done his DM. He has done DM from PGI Chandigarh and IMD in psychiatry from SMS Jaipur. He is currently consultant psychiatrist and addiction treatment specialist director, Center for Addiction Recovery, Rajasthan at Jaipur, Rajasthan Hospital, RHL Jaipur. And he has a number of publications in both national and international journals. He was organizing secretary of one of the wonderfully hosted and conducted conferences, which is Adicon 2023. I think people still remember the way Raghav has conducted that conference. He is also IMA Central Working Committee member from 2015 to 16. And not mentioned here, he is also a very active committee member of APSI, Addiction Psychiatry Society, where both of us are heading one of the committees. And Raghav is there is no better person than Raghav to talk on this topic because of his both in terms of his DM training in PGI Chandigarh, where he has experience in terms of looking at how addiction treatment happens in a government setting with a general hospital setting. Also, in terms of his wide experience in the last 10 years, last so many years working in Rajasthan and working with addiction treatment center and also as a part of a general hospital setting. And I think this is one of the important topics because we read or we study about integration as one of the best ways to go ahead in terms of reducing the treatment gap for a substance use disorder. But it is very challenging, and if done effectively, it makes a lot of wonders. Maybe I'll ask my co-chair to also talk about Raghav Shah and also about this topic. Over to you, Dr. Mahesh.
Good evening, everybody. To Dr. Mahesh. Thank you, Dr. Vishal, Dr. Siddiqui, and all my fellow colleagues. Co-chair Dr. Venkat. I think, meet last month, one of the addiction psychiatry conference, and we have lots of discussion regarding the addiction-related issues. So today's topic is with Dr. Raghav, stigma. I think we all who are working in the field of addiction, we always observe that patients always say that it's a moral failure, loss of willpower. All these things we frequently encounter among the patients. Even our fellow colleagues, they frequently say that you just willpower and you stop the alcohol. Correct treatment policies or as a health illness, that should proper advice should be given to the patient. That is probably affecting due to the stigma among clinicians, among society, even persons who is framing the laws, and even social media. We all see the stigma related to treatment of addiction. So we welcome Dr. Raghav and hope he will give justice to his topic and we learn from him. And now hand it over to Dr. Raghav. Welcome.
Thank you so much, Dr. Mahesh. Now, I think we can start with the presentation.
Yeah, you can share your slides.
Yes, sir.
Yeah, we can see.
I'm just trying to make it full screen.
Yeah, sure.
So it is full screen now?
Yes.
Yes, thank you. So it's a pleasure and an honor to be here in this episode of Thursday Musings. I have been hearing it since a long time, and to be as a speaker here is a great opportunity. I must thank Dr. Vishal Chabra, Dr. Aleem, Dr. TSS Rao, Dr. Tofan Pati, Dr. Shobhit, and my chairpersons for today, especially my friend Dr. Narasimha. He is very busy these days. They are organizing a wonderful conference, CAMCON 1.0, which is the first addiction medicine conference of NIMHANS. So the traction that they are getting is very good, and it is a promising academic program. So it needed a mention here. And also, I acknowledge Dr. Mahesh Sudhar, who is another chairperson for the today's session. So, with this, I would like to begin with the discussion for today. So, the topic for today is regarding accessible and a destigmatized addiction treatment availability in general hospital settings. So, a little bit about me, as has already been told, but I'll begin with this presentation with the evidence available as of now, the current treatment scenario for addictive disorders in a general hospital setting uh, in India, as well as relevant references from the world over. And then in the later slides, I will come to the workflow for addiction patient. Yeah, in the later slides, I'll come down to the workflow for a patient or a person with addiction who comes to a general hospital and how they can be managed to the best. So, a little bit about my workplace. So, I am in a multi-specialty or rather a super specialty hospital setting, and my conceptualization when I started this facility in Jaipur was that how we can have a addiction treatment service which can operate at different levels. That is, as an outpatient service, in liaison with the psychiatric treatment service, as a re- reference or opinion service for patients admitted in other specialties, and provide a short detox or a assisted withdrawal and relapse prevention service. Because in a general hospital setting, mostly the patients are there for their acute needs. Rehab and them for opportunistic means. They may not have presented for their addictive disorders, but due to some other medical disorders, which may be comorbid or which may be a complication, which is due to their addiction. So, it is imperative to mention that the burden for addiction in India is huge. By huge, this slide from the magnitude of substance use in India survey 2019 shows not just the percentage or prevalence, but even the numbers. So we can have an idea that what we are dealing with. In these, the users are multifolds as compared to the dependent users, but the service utilization or the need for treatment is very high among this group of dependent users. And if we see overall treatment gap in India, it is staggering. That is around 86%. So it will not be a overstatement when we say that persons with addiction are mostly too manage themselves or fair to themselves is the approach because of many reasons, including resource limited settings in various parts of our country. But this is what we are dealing with. So majority of our treatment systems are in terms of general hospitals or general outpatient clinics. So if a person with addiction does not find it easy or accessible in terms of approaching these services, then leaving them to the few and specialized psychiatric or addiction treatment service would be a very difficult task in terms of managing these patients. So, if we see from a rights based approach, de addiction services are a basic necessity in these times. And unfortunately, the actual incidence and prevalence of addictive disorders is on a rise compared to many other disorders which are more or less similar in prevalence but are increasing in numbers due to the increase in population. Here there is an actual increase in incidence and prevalence. So this is a basic necessity. With this frame of mind, if we approach addiction treatment, then we would realize the need for the general hospitals. And if we go to the service division, that is what is being catered by a private sector and what is being catered by government sector, then we realize that up to 70 to 80% of our health services are actually in private sector. Some people may even quote a bigger number. But if we see the addiction treatment services, then we see that in this pyramid of services, most of the guidelines, most of the processes regarding addiction treatments in formal settings are basically available at tertiary level government teaching hospitals or general hospitals in a lesser structure. So, reading about these in terms of the various guidelines of Ministry of Health, Ministry of Social Justice, and from our apex bodies like NDDTC AIMS, NIMHANS, we can understand that the number of persons in catering to the needs of these patients is quite less, but the wide community based interventions, they are somehow missing. But we'll not just talk in terms of broad experience that how much they are missing, we'll also see in the later slides. So there can be different levels where different levels of services can be available, and there should be a smooth crosstalk that a patient who may enter at any of these levels should be easily mobile among these different levels. And here we have to understand that many of the patients are entering treatment services where they themselves are actually not seeking treatment for addiction despite them needing it. So, how we can utilize this opportunity or this opportunistic interventions can be administered to them. So, what are WHO recommendations for a good addiction treatment? So, utopian conditions or ideal conditions would demand all these uh, factors to be present in a good addiction treatment services, including conceptualizing addictions as a chronic health condition. And if we see the drug de-addiction program of Government of India by the Ministry of Social Justice, it also conceptualizes addictions as a chronic relapsing medical condition comparable to non-communicable diseases, that is the NCD programs. So if we see it as a medical condition, and if we understand that accessing addiction treatment is a right of the person, then we need to integrate it with other medical condition treatments in a general hospital. So, accessibility is availability and beyond. So, firstly, we have to make these services accessible. What will be these services, that also we'll talk in the further slides. But accessibility is not just availability, because we can understand that persons with addiction are a group which are considered to be at risk of human rights violations. If we see the guidelines of Ministry of Social Justice, they handle a lot of addiction treatment. We would actually see a tilt in favor of social justice ministry rather than the Ministry of Health in terms of the various programs guidelines being run. So this is a at risk group. They are generally not able to defend their rights and seek treatment rightfully. For example, a person with a fracture or any liver disease would be seeking his treatment rightfully. He would be backed by insurance services. He would have a lot of support from his family, community. But a person with addiction is already marginalized. And to seek treatment in an adverse environment where there is a lot of stigma, the communication is loaded against that person, where terms like recidivism, alcoholism, all these stigmatizing terms are still there. So even if the first step is crossed of accessibility or availability, then making it accessible requires addressing the stigma also. This is a basic conceptual framework for overall healthcare accessibility. If we see various determinants for it, then characteristics of delivery system are important, but characteristics of patients at risks are also important. Many of them are factors which are against accessing treatment for persons with addiction. Like, for example, sources of finance, health insurance, being able to bear the cost of treatment in general. If we see the concept of price elasticity of demand, then we know that increasing the cost of addictions also does not deter those who are already dependent on it. They, in fact, dedicate more and more percentages of their income to finance their habit of addiction. And then uh, they say that poor are actually at a greater risk overall from addictions as compared to the wealthy. So, in a lot of these factors, we'll discuss which are more pertinent to addiction. Stigma. This is a very important factor. A little I have discussed in the previous slide. We'll talk about it more, that how something is just at your arm's length, but you cannot access it because of the stigma. So, this is from a study from Philadelphia. It's quite a recent one. So, this is about role of addiction medicine consultation service in a community hospital. So, from here, just as a reference, we would see that how people in a general community hospital setting access addiction treatment for which reasons. So, we can see that in US, in Philadelphia, the major reasons for consultation are in this order, that is ongoing substance use disorders, that they are basically consulting for their addictions primarily. Then management of withdrawal symptoms, then management of overdose and toxicity, pain management in patients with substance use disorders, medical management and dose titrations, and screening of any substance use disorder where the patient may not have actually presented for that. But in India, we cannot assume this to be directly extrapolated. So, what could be a ideal addiction consultation service for persons hospitalized with substance use disorders? Why we are talking about hospitalized patients? Because OPD treatments are generally more voluntary and they are in a form of a implied consent for their treatment. But persons who are hospitalized for different reasons in different departments of a hospital, where many a times we get a call to see a reference, we understand that there is no implied consent. So we have to basically engage with those patients, provided their physical health conditions allows that at that moment, and we have to motivate and bring them into the treatment. So this is the concept of a opportunistic interventions. And here there is a opportunity as well, because in an acute situation many times patients are receptive who may not have entered the treatment pathway for addictions otherwise. So where lies the opportunity? General hospitals, if we talk about general hospitals, we talk about a hospital which is a non-teaching hospital, which is more like a service oriented hospital with multiple departments. If we have that conceptualization in mind, then general hospital have many of the resources necessary for effective interventions for persons with substance use disorder. Firstly, there is a rapid access to medication treatments. Many a times in doctors who are practicing in their clinics or in the smaller community level hospitals, some medications for addictions, maybe due to the legal framework around them, maybe due to other reasons, are not accessible, like opioids for substitution, medications of the narcotics categories. Then medical staff that can diagnose and administer treatments. So the staff is there in place. It is about us how we sensitize and train them to deal with such patients. Social workers who can facilitate linkage to addiction treatment. This, as a category, may not be there functionally in many of our hospitals, but medical social workers and where applicable psychiatric social workers, if they are present, they can facilitate linkage to treatment and continuation of recovery support and medical care in outpatient departments. So the patient may not follow up with you as a psychiatrist or addiction treatment specialist, but they would be following up with their respective specialists. So there can be an opportunity for continuation of recovery support in the medical care in outpatient departments. But then opportunities come with challenges. So where lies the challenges? Most hospitalized patients with substance use disorders do not receive adequate services, overarchingly because of stigma, hospital staff knowledge limitations. This may include the doctors, the hospitalists, or the residents who work closely with the patients, spend much more amount of time compared to the senior consultants. Then socioeconomic disparities in access to care, and in a private setting, very importantly, lack of insurance support. While there would be an insurance support for your liver disease, which is an outcome of your alcohol dependence, but only to the point that your physical uh, recovery or physical management is done. Beyond that, 5 days, 7 days later, what will be the condition of a patient in terms of the actual problem that he's facing? Then linkage to those services or treatment for those is not covered by insurances. This is a study from Boston regarding acute care hospital utilization among medical inpatients discharged with a substance use disorder diagnosis. So this was more of a retrospective study where 738 patients were assessed, and what came out was that nearly 17% of discharged medical patients had an additional diagnosis. So roughly, if you go conservatively also, 1 in 5, nearly 20% of medical patients have an additional diagnosis. The statistics may vary, but acute care hospitalization or repeat emergency visits are common among these patients. And among them also, with the combination of alcohol and drug use, is those at the maximum risk. So these patients can be a very important target in a general hospital setting for opportunistic interventions. By opportunistic interventions, we again reiterate that these are the patients who are actually not seeking treatment for substance use, but these are the patients who would benefit maximum in terms of engagement in treatment if they can be motivated. So, how to utilize these opportunities? This is like a rapid chess. The patient is there for a limited time. He may just complete his emergency needs. He may be there only till the time that his other treatments are going on. So we have to engage with them and capitalize on these teachable moments. So major aim of engagement could be reducing the harm, promoting behavior change, and linking individuals to treatment when they encounter the health system for any other reason. It is very important to understand that treatment target can be very different for three major stakeholders: the treating doctor, the family of the patient, and the patient himself. And we need to remember that addiction treatment is basically a shared decision making rather than a directive treatment. This is where a lot of communication gap and failure of rapport happens, because the treating team and the family might be at the same level of advising or even being directive to achieve abstinence, but the patient may be looking towards harm reduction. It is very easy to understand that any alcohol user or any substance user who is having problems or harms due to that substance would want to reduce the harm. But would they want to stop the substance? Not sure. So, if there is an open communication, that question can be answered. Patient may have a better rapport, and then you can engage him into treatment and help promote behavior change. So, what could be those rapid engagement strategies? Capitalizing on those teachable or acute events, motivational interviewing approach, from where the patient may actually conclude rather than you telling him. Then concrete and real time feedbacks, like a patient admitted for a pneumonia or a COPD exacerbation. You can give a real time feedback that he has stopped smoking and there is an improvement. Despite all this, we may need to roll with resistance because the patient may not be willing for the treatment at the moment, but that should not let you to assume that he is not willing for the treatment itself. Let's wait for the right time. Client autonomy. Substance use treatment is actually a treatment where rights of a patient need to be respected, because the classic loss of insight or not knowing one's own good is not applicable as such, except for periods where person is in intoxication or they may be in delirium or in some comorbid psychiatric conditions. Otherwise, a person with addiction should be allowed autonomy. Then addressing the underlying triggers, making treatment accessible and convenient. Value for money and availability. Value for money, because it's a very strange fact that while a person may strain his resources to fund his addiction, which is not a choice but a compulsion as such, but when they see that the treatment is prolonged, costly, then their motivation may be disturbed. So, making treatment value for money, and treatment value for money of treatment doesn't simply mean that you reduce your treatment costs, but it is about making the person understand the long term impact that this treatment can have in their lives and not just in their physical health. Many a times we feel that seeing a reference in some other department would be just a like a signatory exercise, that we just have to go and see the patient. That's many a times the attitude of the consultants in other departments. But if we see what could be the most important motivating factors for change, this would be believing that one would get sick if substance use is continued. We often come across a relative, wife, father, brother, anybody saying, "Doctor, please scare this patient." We as psychiatrists sometimes feel that just scaring may not help. Of course, scaring somebody may not help in long term behavior change, but initiating behavior change, this may be very important because physical health is important to everybody. Then, physical health concerns. Many a times, there is a delayed discounting of the harms due to substances. If the harm due to smoking is there 10, 20, 30 years later, then the motivation to change reduces despite all those scary photographs on a tobacco packet. But if it can be actually linked to a physical health concern, which is understandable and patient can relate to it, then this could be a very good motivation. And many a times patients are just tired of using a substance. They may not have a fine understanding in terms of what harms that the substance is causing, but they might be simply tired of using the substance. So if these kind of feelings are being given out by a patient, then there is a good chance of him moving up the motivation cycle. From here, the SBIRT approach comes into picture. So this is the article from Thomas Weber, from which there has been the SBIRT manual, which is freely available on the WHO website. So here we have to actively screen for patients who are experiencing problems due to substance use. Here, the patient may not give you the full information, but from the treating team, from his family, then we have to engage with the patient in a brief intervention approach, the classic frames approach that we have seen. And then, if the patient is willing to go further in treatment, then referring him to the right treatment approach. Referral is very important at times because many general hospitals do not have a addiction treatment service, sometimes not even a psychiatric treatment service. So overall referral and linkage to the right treatment, that is matching the person with the treatment he needs, would be very important. Many times in your community we do not know and are not aware about where the required treatment options are available for the patient. The patient may actually need a therapeutic community or a long stay. The patient may require a rehabilitation in a non medical setting, the classic NGO de addiction center approach. The patient may require follow up with a psychiatric treatment service and actually a integrated treatment service where his mental health and psychiatric needs could be addressed together. So all these things, the medical staff in a hospital, if they are sensitive, then they can do it. And regarding brief interventions are a very simple approach, and brief interventions can be learned and practiced by non doctor staff, that is the nurses, even other people in a hospital setting who are closely working with the patient. This is from a relatively older Cochrane review where the benefits of brief interventions from heavy alcohol use who were admitted to general hospital settings were clearly visible in short term. In very long term, of course, greater studies are needed, but that short term, that period of a few months where you could have a relative change in the behavior of a patient could always be capitalized in involving him for a longer term treatment. Now, how to reduce stigma and improve acceptance? So, value of peers in a hospital setting. This is just like testimonials where we see when we go to any place where we have to like decide that we want to have this thing or not. If there is a person who is giving us his experience, that helps to build trust and credibilities. Many doctors on their websites, their Google pages have the testimonials. Then importance of a caring and non-judgmental staff. As soon as the patient speaks that he takes a lot of alcohol or he takes drugs, and if there is a change even in your body language, which kind of is exclamatory or in a way judgmental, then this uh, stops the further communication from the patient. Hospitalization serving as a wake up call. Mortality is motivating. This is true. Although we know that for a long term, this is not true because the patient, once they have an improvement in their physical health condition, their motivation to give up substance also reduces. But if we could capitalize on that time, the importance of choice, again, it's a client autonomy and a treatment of shared decision making. Then access to medication assisted therapies. If these therapies could be available in a general hospital setting, for example, OSTs, buprenorphine, if we talk about other substitutions, and even if not substitution, then the availability of medications for sleep, for pain, for opioid substitution, if they could be there in the general hospital setting itself, then a lot of stigma would be reduced. Patients would not be exposed to unlawful and human rights violating approaches of so-called de-addiction centers at many times where the human rights and general approach of a patient treatment is not followed. The need for a coordinated timely care after discharge. Maximum patients in a general hospital setting, if they access addiction treatment while they are hospitalized or while they are consulting for other health conditions, they mostly are forgotten after they are discharged. But then, if we could somehow have a team in place or link them to a team who can provide them aftercare, that is follow up care, because we need to be reminded again and again that addiction treatment is that of a chronic disease of a relapsing nature. So, relapse simply can be a rule for many patients rather than an exception. So, if we know that and if we can have that aftercare, it will be very beneficial. Hospitalization should address life stressors and trauma. Many times in general hospital settings, especially doctors in other specialties, they are mostly concerned with the problem of the patient and treating it. Like a surgeon who would not go very deep into your life condition, your life stresses, relationships in your life, the overall psychosocial wheel where all you could have problems or traumas. They would just simply be nice to you. They would give you relief in your problem, but they would not go into these areas of your life. So, if they could be sensitized and if a team could be there in place, then chances of accepting addiction treatment and following it would increase. Then, hospitalization should address basic needs also. By basic needs, we mean that general improvement in a patient's life condition is important to overcome addiction in many cases because the overall psychosocial improvement is important. If we see the addiction severity index, we know that the physical and psychological harms due to substance are not the only harms. Many a times, family, work, finances, legal issues, so many other things are there. So, if they could be addressed. So, now coming to how to improve addiction treatment services in a general hospital. In a general hospital setting, first we have to understand that there are diverse partners or stakeholders, and we need to build up an interprofessional team that includes physicians or doctors of other specialties, social workers, and peers. Peers is very important in that way that these are mainly persons who have been stable in recovery from addictive disorders for some time. We think that how can we engage people who have recovered from their substance use, but if we see the guidelines for the de-addiction centers in India and abroad, they always include a post for a peer educator. Why peer educator? Because somebody who has overcome a difficult, complex problem you are facing will always be a good role model for you. Although they have a underlying that being stable in recovery for 3 years, 5 years, that is there. And even if we see in India, most of these de-addiction centers, which are like a hallowed place, they are mostly being run by persons who have been in recovery. Although there can be a criticism, they are not in recovery, they are still using substances. But if these could be there, and a very good peer support program is the 12-step Alcoholic Anonymous program. Even if I talk about PGI Chandigarh and our drug de-addiction center, there used to be a weekly session of Alcoholic Anonymous. The persons who were voluntarily involved in that used to come, and patients who felt that they needed a support system after discharge for their recovery would engage with them. So, engaging peers in your team would be very beneficial. Evidence-based detoxification and relapse prevention. This again is very crucial because many times patients may not want to give us substances simply because of fear of facing severe withdrawals. We commonly come across patients in other departments where their family members are simply giving them the opioid that they have been consuming, be it a natural opioid like opium, Doda post, those things, because they know they will not get sufficient treatment for that in the hospital, and they would be so distressed that they would not be able to actually take the treatment for which they are there. So, evidence based detoxification and relapse prevention services need to be developed in a hospital. The patient needs to have that faith that they would be in safe hands because actually they have not come for addiction treatment. For this, we need to train the hospital staff, especially those having maximum contact with the patients, like the general duty medical officers, the intensivists, the resident doctors, and the nursing staff. This is from a addiction medicine consultation service in Oregon, United States. So over the years, how they have linked persons with addictions from a general hospital to different services. So we can see there is a umbrella of services: withdrawal management services, specialist care, socialist services, residential treatments, private counselings, primary care providers, local addiction clinics, and many things. Although in the similar rubric, these services may not be available in India, but the concept is that we need to be aware where those patients need to be linked if you are working in a general hospital setting. At the policy and delivery systems levels, also, we need to make those changes. There are a lot of treatment opportunities in government centers, medical colleges, teaching hospitals. We all know addiction treatment facilities. These ATFs are the latest conceptualization of government in the Nashamukh Bharat Abhiyan, where in district hospitals run by government, those facilities are being developed both at outpatient and inpatient level. Then the OST centers, a big problem because of the legal complexities involved. Then the district mental health programs and others. Treatment opportunities in the private sector. I would focus more on private sector because of my work setting there, and also because, as we discussed initially, that more than three-fourths of the healthcare is being provided by private sector. So, how private sector can provide those opportunities for persons with addiction? Of course, if there are psychiatrists available, if there are addiction treatment specialists available, OPD services, consultation liaison services would be very important. But we also need to understand that the person who has been in the hospital for any other need would be better placed if they could complete their withdrawal management, if they could complete their basic beginning of a counseling or a relapse prevention plan in the hospital itself. So a short term detoxification and a rehabilitation program, if could be available in a general hospital setting, would be very beneficial, especially for those patients who may not have a very high degree of psychosocial problems in multiple spheres of life, so that they could have a short stay of treatment and then get back to their lives where they are working in a job, in a business, or any other responsibilities in life. So here, now after that we have discussed this, I would take another 5-10 minutes to complete the presentation. I would just put forward the workflow for us in a general hospital setting, wherein I am placed in a super specialty hospital setting. So when we thought about this, then we thought that we need to provide the legal framework also for these patients. So in on the basis of the NGO we are running, we took a license from the Ministry of Social Justice for the rehabilitation part, which could be a few days itself, and from the Mental Health Care Act, of course. So, what could be the best practices? Rights based and a patient centric approach, a voluntary addiction treatment approach, mutually agreed upon plans, and patients' right to seek discharges. Because many a times addiction treatment program is sought in a way that the patient doesn't know his best. He needs to complete 15 days. Many times attendants also ask you, okay, how much would be the expense for 1 month of treatment. But then we have to understand that there is no fixed line of a month. This is a shared decision, and how we can provide an integrated treatment would be the important thing. So various substances and behavioral addictions are also like coming up. An integrated treatment approach would be if we could provide these 4 5 major areas to whatever extent we can to a patient. Of course, we would need a team for this, and we need to work on that, where a psychiatry service, a addiction treatment service, if not separate, then the same, could liaison with different areas of the department of the hospital, and we could have other mental health professional on board, like counselors, like social workers, and peers. So we could have a medical management, of course, but wherever required, individual therapies, group therapies, if we could provide it there, better. If not, we could link to those services, and a eclectic relapse prevention program could be managed. Why eclectic? Because relapse prevention program doesn't have a structure. It is a semi-structured approach wherein a patient may have more of psychosocial needs, some patient may have more of medication needs, and different things. And we could have an inpatient facility which could address these needs. Many times patients ask that why can't the patient be admitted in a hospital for addiction treatment? There are various challenges, legal, for which I just discussed that we are eligible for licenses in a general hospital setting also. Then there are things related to the team, because addiction treatment requires engagement with the patient at various levels. So, if we could have a separate area in a general hospital where we could like give the patient a more or less private stay with family, without family as required, because it's a voluntary treatment, and link him with overall recovery program or a relapse prevention program where not just medical treatment but a lifestyle change, a structured daily routine, those things could be addressed. And the basic process could be where a assisted withdrawal management or a complicated withdrawal management if required, because in a general hospital setting you are well placed to manage a complicated withdrawal also, which patients may be at risk of seizures or delirium or any other substance, and various professionals could engage with the patient. And then medical comorbidities, psychiatric comorbidities could be addressed, and an active follow-up program can be there. So this is the ideal, but we have to understand wherever we are short of that facility, if we could link the patient and refer him to that facility, like a integrated approach for dual diagnosis. So overall, a individualized therapy may be required for a lot of patients, but many patients may also be benefited by a support system approach or a 12-step approach. And we should be open because if a patient is linked to these kind of programs from a general hospital itself, then he could be managed in a functional way and may obviate the need for that patient to be admitted against his will into a de-addiction program for a fixed number of days, which may not be necessary for him. And overall rehabilitation, recreational activities, many a times these seem more like that they are not something which a doctor should recommend. Of course, we cannot recommend any specific yoga therapist or a meditation expert, because many of these therapists, like music therapy, art therapy, all these things may not be professionally licensed as a program by the government of India. But we can, of course, refer people to psychologists who are licensed, who are working. But patients need a kind of our validation and approval, because a patient family may feel that if this patient is regularly engaged into lifestyle improvement, physically fit, then he would do better. So if you can like validate this where required, of course not just by the will of the patient. So this could be an overall program. So to conclude, what I would say that addiction treatment services at a general hospital level are a basic necessity. So we need to remind ourselves. And accessing addiction treatment in a general hospital should be easy access, just like treatment in any other specialty. You should make an environment or try to make such an environment that a patient, as easily he comes from a orthopedic treatment or a physician treatment, should be comfortable to seek addiction treatment. For acknowledgements, I would acknowledge Dr. Shambhu Prasad, with whom I had a lot of discussion regarding this topic, and I would conclude my presentation here. Thank you.
Thank you so much, Dr. Raghav.
Thank you, sir.
Thank you so much for presenting us a new, we can say, opening up a new channel for us. Over to chairpersons for their opening remarks. Questions are invited in the chat box.
Thank you, Dr. Dicky. Uh,
You can stop sharing the screen.
Yes, sir.
Thank you, Dr. Raga.
Yes, sir.
Very important discussion, today's topic, stigma, which is related to the addiction and how it affects the policies and treatment in the hospitals, how the services should be provided. Chat box, we have few questions. I like to address these questions. First is from Dr. Roop Sidana. He is from, I think, Rajasthan, Ganganagar. It's a very important comment. He says that follow-up care after discharge is the most important factor for treatment to be continued with the patient. Patient should be follow-up when I feel that patient relapse. He should be always comfortably feel that clinician or a psychiatrist is always there to help him, and he should be comfortable to contact and easily accessible. Then I think that's very important. What is your take, Dr. Raghav?
Sir, I totally agree with you. Especially in private sector, we are. But I'm not saying the persons in doctors in government sector are not answerable, but in private sector, it is more like a service delivery thing because of the payments involved and so many things, mindset of a patient. So if somehow, even if the patient cannot reach to us, but there could be people in between, and where required, the patient can reach to us. This would provide us very important events where the course of the treatment may change if the response from the treatment team is not there. So we should engage.
And I think the most important factor would be your relationship and empathy the patient feels towards you. That will decide the outcome of the treatment. Most of the patients probably improve with this feeling that clinician is helping me, and whenever I get the problem, I can contact and I again get the help and I come out of it. That relationship with the patient factor is very important, according to me.
Right, sir.
And the second question is, what is the role of brain stimulation in addiction treatment?
I think I will answer it, but Dr. Narsimha, which should be very well placed to answer this. As far as yes, sir. The transcranial magnetic stimulation, uh, as far as the reviews that I have gone through, they can have effect in craving as an independent variable, because many times we think that craving is a result of something, maybe a mood, maybe physical withdrawal, but the actual craving, which is independent of these, expressed by patients as कि बोर होने पे या कुछ नहीं है खाली हूं इसलिए आई वांट टू यूज अ सब्सटेंस, those kind of things sometimes can be very frustrating for a doctor. Therein some studies show some effect with brain stimulation,
Actually, it is
and they
approved.
may.
Yes, it is approved for nicotine addiction. It has a FDA approval. Other addictions, there is an evidence which has been coming up, but only for acute phase, for maintenance phase, which is very, very important in addiction. I think we need more
Yes.
data. Dr. Raghav, I think a scholarly presentation, I would say. But I have one very key question which we are struggling in Uttarakhand here, that we have so many NGOs cropping up which are admitting de-addiction patients. And that is inflating the stigma around it, because obviously the treatment facilities are not ideal, and there are a lot of off issues which are happening in these places. And then when they are coming to us in acute, in general hospital setting, in wards, so they are already so much stigmatized by the name of rehabilitation or de-addiction. So how to counter this scenario?
um, if I am understanding your question rightly, that can you repeat the question?
What I mean to say that so many NGOs are admitting these
Hmm.
patients in the name of rehabilitation centers. So
Yes.
it is a lot, I think 100 plus in Dehradun itself.
Okay.
So, and
Right.
the treatment which patients would receive is subpar. So, and it inflates stigma, because then for them the de-addiction is something which is very acrimonious kind of a thing. Now, how to go about it? I know it's an administrative issue.
Hmm.
Your take on it.
Right. So first of all, I would begin with an apology. I just missed that Dr. Shobit is an expert in uh, magnetic stimulation. We had in fact asked for his presence in our conference, but that time somehow the things didn't turn up. But regarding NGO de-addiction centers, see, the problem is that the NGO de-addiction centers are not being treated as a healthcare facility. Clinical Establishment Act, Mental Health Act, those things are not applicable. But we should know that the rate of comorbidity in patients with addiction is very high. If psychotic conditions may not be that prevalent, but overall depression, mood disorders, anxiety disorders, so many of these patients are abused in terms of their rights. So these de-addiction centers require to be treated as a hospital because they are administering medicines, they are treating patients. So a person with addiction is a having a illness which is diagnosable according to World Health Organization. So ek to they need to be regulated by all three things: as a clinical establishment, as a mental health institution, as well as a rehabilitation, which is the social justice license. These de-addiction centers, because they are not being regulated at all these three levels, so many a times the persons are being abused, and they have a very strange approach. They would tell you that if the family members would meet the patient often, his motivation would lose. So they somehow let the family members also meet the patient at the end of a month. By the time a lot of water has flown, actually the person comes out with resentment rather than a sense of recovery. And they are like revenge drinking or like trying to take out their frustration on their families. So these centers, I think, should be regulated in these three aspects so that the right professionals are working there and the patient's autonomy should be there.
Agreed.
Dr.
Okay, I think
Dr.
Dr.
Narasimha.
Dr. Narasimha wants to say
Sorry.
something.
Yeah.
Please,
Yeah,
please, sir.
I think just wanted to add to what Raghav has told for Dr. Shobit Garg's question. In terms of, as Dr. Shobit has highlighted, that it's an administrative thing. So I think one of the states I think this is a problem across the country about these NGOs. Again, it was something that was promoted by government, but in terms of small agencies which are not associated with health coming up with the de-addiction center, one state, Tamil Nadu, has actually come up with the Gazette minimum standard guidelines, which actually differentiates between both acute care and long-term care, and actually details down who can actually provide the acute care, who can actually provide long-term care, and defines each and every aspect. I think this is also something that we wrote about on Indian Journal of Psychiatry, where this minimum standard guidelines was gazetted. So I think after that gazette, there has been, at least to my understanding, some changes that are happening in the state of Tamil Nadu, and uh, I think many other states are also following it. Not many states. I think at least now three states have this minimum standard guidelines which are gazetted. So it's a kind of an act in that particular state.
Excellent, sir. Thank you for this information.
Add something, sir. Every rehabilitation center who is treating patient of substance abuse or mental illness, they should be registered under Mental Health Care Act.
Yes.
So that is a requirement of the law, and that has to be followed.
Dr.
Is
Roop
it
Sinha makes to want a quick comment, I think.
Yeah,
Roop, sir.
yes. In response to Dr. Shobit Garg's comments, I would like to say that it's a common problem. People getting admitted into so-called rehabilitation centers, which are run by non-medical personnel under no supervision, and the patients spend months there, and when they have acute problem, they come to us, and it's surprisingly and annoying that those people who have stayed in the hospital, in the rehab center for 3 months, they would not agree to get admitted for a week or 10 days in psychiatry hospital or general hospital psychiatry unit. And secondly, all these rehab centers in Rajasthan, there are guidelines in the Gazette for these rehabilitation centers, but those guidelines are not implemented, not followed. Rather, the Department of Social Welfare and Human Empowerment, they have misused these guidelines to inspect the de-addiction clinics. Any psychiatric center, OPD hospital or a OPD center, if they have written a de-addiction on their signboards, these Ministry of Social Welfare and Justice, they come and inspect these premises and want to see whether the rules are followed or not, rather than looking at the centers which are to be regulated. So I think the Mental Health Care Act, if it is implemented in true spirit, these problems can be solved. Thank you.
just to answer my question to everyone, including you, sir? Why did this happen? I mean, why does this Ministry of Social Justice issue keeps coming when it's clearly a mental health issue actually. Forget about mental health, the health issue. So anybody has any idea why is this still? I mean, why is Ministry of Health? I mean, Ministry of Social Justice. Where is social justice in addiction? What is the point here?
Sir, our Home Ministry has initiated this Nasha Mukt Bharat Abhiyan, and Nasha Mukt Bharat Abhiyan says they say that addiction is not a problem of only the medical field. It's a problem of the society. It's a problem of the law enforcement agencies who are managing the culprit prevention of the addiction production, addiction selling. That has to be done by the Home Ministry. Treatment part, that should be done by the Health Ministry. And awareness, rehabilitation, and awareness among the society, that should be come by the Social and Family Welfare Department. So all 3 and 4 agencies, they should work together to curtail this addiction problem. That's why Nasha Mukt Bharat Abhiyan was initiated, and all 3 ministries are included in this program. So this is initiated by our Home Minister that it should be go like this, rather than independent agency can do certain things in particular area.
Thank you, sir.
Right.
Thank you. Dr. Raghav, can you
Yes,
just tell how is addiction treatment in general hospital setting different from a dedicated de-addiction center. Is there any difference in treatment?
So, see, in a general hospital setting, we are mostly dealing with persons who are in need of withdrawal management or detoxification and uh, follow-up treatment. So, in a general hospital setting, there would be a lot of patients who would be having mild to moderate level of problems due to substance use or a milder levels of dependence or severity of dependence. In rehabilitation centers, we are mostly dealing with persons who have overall higher severity of addiction. So, by severity of addiction, we do not simply mean the level of withdrawals only or level of amount of substance being taken. Problems in multiple areas of life, like losing a job, having poor family relations, at risk of a divorce, financially being like ruined, many things, legal issues, so many things. So the patients in a general hospital setting are mostly having lesser severity of addiction and mainly need medical and psychological treatment to overcome their disorders. But in patients who are presenting to rehabilitation centers, they have multiple problems and they also have a unique issue of not accepting treatment or not having a will to undergo treatment. Although this should be addressed in a different way, there can be approaches for some kind of a legally mandated treatment. But going illegal, detaining those patients actually increases the overall criminality and the resistance in those patients. So it's almost like a detention for them. So these would be the two different groups of patients who present to general hospital and rehabilitation centers.
Are there any difference in treatment protocols also?
Yes, sir. In general hospitals, there would be more of a shared decision making. Patients' autonomy would be there. They might be also having a lot of comorbid conditions, many of them having comorbid medical conditions, many also having comorbid psychiatric conditions, or all three at a time. And in general hospitals, patients are also there for harm reduction many a times. They may not have a aim to give up the substance, like alcohol is necessary for socialization. So their aim may not be to be abstinent. So this is a very different client-driven patients that we are seeing in general hospitals. But where addiction treatment is driven more by families, by compulsion of the person's situation, those are presenting more in rehabilitation centers. If you see in rehabilitation centers, a very interesting thing is they mostly give medicines for any kind of condition only for a few days. Their intention is not very noble. Their intention is like they would not want to escalate the cost of treatment. And second, many of these are outcome, the run people who run these rehabilitation centers are outcomes of these 12-step approaches. They have a firm belief in 12-step programs, and if you see the grapevine of the Alcoholic Anonymous group or the 12 steps, they basically say that medicines are not required to give up addiction. Although we see the outcomes also, staying in a rehabilitation center for 6 months and coming out, and the first thing is going to a theka, coming out after 1 month going to a Teka. In fact, the rehabilitation center people are so against medications because I did go to a rehabilitation center, the typical classic NGO one. Because when I finished my DM, it was COVID time. So then I thought what to do, let's see this. So I went there for 3 months. They were so against disulfiram, they were so against chalo buprenorphine is a psychoactive molecule, then maybe you don't want to give, but why not disulfiram? So there is a very
Yes.
Ajib kind of a motive where they feel that the patient, if they doesn't relapse, they
The,
won't come back to them.
Dr.
So
Raghav,
I'm
the
not
this,
reason
talking
for that
about
is
bad de-addiction centers.
Sir,
no, but
sir,
no,
most of
but this is how it is,
rehabilitation.
na.
sir, I agree
Acha,
with Dr. Raghav because
okay.
Let me just add here. Let me just 1 second. I've been to many de-addiction centers in around Delhi. They basically run by ex-addicts. And they
Hmm.
think because they could manage to stay, sane or stay out of abuse for last 10, 15 years, this is the only way out. And medications are useless. That's what they
Yes.
continue to believe strongly, despite me trying to help them, understand them, trying to say, let's do A also, let's do psychotherapy also, let's do medication also. And especially
Yes.
medication when you have to discharge the patient. Please send the medication on some medication when you're discharging them. But they don't do that. And the people who recover, First of all, most of the people don't recover. When they recover, they come back and join these rehab centers as assistants to these people. That's the whole cycle.
Hmm. Baki, Dr. Siddiqui had a valid point that there are some ideal rehabilitation centers also. There are some in Delhi, there are all over
Yes.
country, which are mostly, as I have seen, are very expensive.
Exactly.
Because
This
then they
next point,
have
yeah,
the
yeah. That's
they
exactly.
are very
So,
expensive. They have
yeah.
the actual right approach, which you see in Chiang Mai, Thailand, or in US, where all the team is there, psychologists, social workers, professionals of different types who actually help patient to recover. But then, sir, this is a very expensive treatment, mostly out of bounds for people. In Delhi, Dr. Chavada knows very well, but as I also refer some patients, I said they are to the tune of 15
It
to
is difficult to
30,000
afford.
rupees a day.
It is difficult to afford for us also. Forget about the other
हाँ
people.
right, sir.
Sir, actually, I agree with Dr. Raghav. Many a times we encourage patients to join anonymous organizations or these programs. Actually, they encourage them to discontinue medication. But if we read anonymous programs,
Yes.
they advise clearly that members should not become physicians. They should follow the medication advised by the doctors. But
Yes.
somehow the message which goes is probably not right.
Sir has, I think, Roop Siran sir has raised that. Sir, you raised your hand again, sir.
In the meantime, how to set up as a center in a general hospital setting? How to build from scratch? Suppose a new general hospital is going on, they want to start this. So what? How? What manpower? What resources? What machines? What all should they collect, and then they make this center?
So, if we see the government guidelines for NGO de-addiction centers or de-addiction centers minimum standards, those kind of guidelines are there. Although they don't say that these guidelines for general hospitals, but we will get a fair idea of the people required. We should minus the administrative people required because administration is centralized in general hospitals. So there will be a common hospital indent, common hospital admission, those kind of things will be there. But treatment team required is basically a psychiatrist, then a resident doctor who may be a psychiatrist or maybe a MBBS. Then you would require counselors who would be psychologists. In a private setting, you may require a RCI licensed clinical psychologist also because many a times you would require to report and that would require a license. But you could have other psychologists who are more of counseling psychologists or having a master's or bachelor's. Then you would require social work. Social worker may be professionally having a degree of a social worker, or they may not have a degree, but you can train a person in that respect because social work is very important. They can like follow up the patients. Many a times, social workers' place is taken by peer educator or the persons of recovery. So your own ex patients can be attached with you, and for them, it is a matlab for both of us, it's a win-win situation because now they are engaged vocationally also. So their chances of recovery are better. And because they understand the patients on a deeper level because of using the substance themselves, then they could be a very good bridge for follow-ups. So I think these would be some minimum things. And the nursing staff, general duty attendants, all these things in a general hospital. One important thing is these are like floating staffs. They may one day be posted in a ICU, they may one day be posted in orthopedics, one day in medicine. If we could like have dedicated nursing staff, dedicated general duty attendants like GDA and staff, then they would become well versed with the communication needed for a person with addiction. So this is how we can like set up a dedicated team.
Okay. Okay.
Correct.
Thank you, sir. Thank you.
Because why
Have
it
we
is,
covered all the questions? Yeah.
it is why relevant
There is a,
Dr.
I think,
Alim's question because comfortable treatment conditions will bring down the stigma. So that is very,
Yes.
very important.
I think Dr.
That is
Gulbahar has
important.
asked two questions, if you can take that. Not exactly directly related to today, but do you agree that we still don't have any effective anti-craving drug? Or do you disagree with that, sir?
No, sir, I agree that there is I disagree. We have effective anti-craving drugs because we have FDA approved medications for that.
Hmm.
4 of the medications, 3 of them are approved: naltrexone, acamprosate, and one more would be disulfiram. Is
Disulfiram.
more of a disulfiram is, but then anti-craving effect is not clear. It is more of a deterrent, I think. But for some
Baclofen?
disorders like cocaine and other things, they also say it has some anti-craving effect. And I think basically these 3 are the FDA approved medications, so they have an effect.
And
And
nalmefene in Europe and baclofen in France.
baclofen.
Right, right, right.
And I think
I,
baclofen is very highly prescribed by Nimhan's group.
and by Vishal Chawla.
Yes.
I like it a lot. Well, it's a very good drug. I think it's a very good drug. We are underutilizing that drug. The wonderful drug.
But no size fits on one solution.
Yeah, that's true, boss.
Either it
That's true.
every
That's
patient.
true. Yeah. Oh, do you want to comment on the role of spiritual gurus? That's another question Dr. Gulbahar
In
has.
context of referral pathways, probably the question is. So whether they can act as a referral pathway for us, Dr. Raghav.
See, basically, we can't, because as I discussed during the presentation, anybody who is not having a valid qualification in our overall legal framework, we as doctors can't refer people to them, but we can have a hands-off approach that spirituality is important. It is your decision whom you want to meet for. And I have seen a reverse thing also. Now, these days, spiritual gurus or faith healers have become very smart. They tell their followers when they need psychiatric treatment.
What we mean
They,
by pathway is them referring these patients to us.
Yeah, that's what he's asking. That's what Dr.
ah,
Shobhit, yeah.
so the other part is very right. If they refer to us, it is very nice. And that also obviates us from naming any spiritual guru. Then, of course,
Yeah,
from where they have come, they will go to them.
yeah.
Thank you. Have we covered all the questions?
Uh,
Yes,
Is,
mostly so.
that government is not giving the budget for the addiction center, and we need more ATF centers in the country. Even state governments are not providing that centers to the uh, general hospital or government hospital. Any comment, Raghav?
The I think need for something is recognized, then only the budget allocation and overall policy decisions are there. I would come back to that social justice issue because I once tried to read it through ki why social justice ministry comes into picture. In fact, even Nasha Mukt Bharat Abhiyan is basically a program of social justice ministry. Other ministries are involved because like for narcotics you need home ministry, for treatment you need health ministry, but if you see the website also, it's basically a program of that. So I talked to some of the people in social justice when we took a license for it. So they said that they are rights vulnerable groups for human rights, which include children, pregnant women, poor people, and persons with addiction, and a few more groups. So they came into picture because persons with addiction few years ago were nobody's baby. Doctors and other people were not much interested, and they had significant human rights abuse because a person who needs 2, 3, 5,000 rupees per day to finance his habit is basically at risk of being abused by a lot of people. Even in the family also, they are like regularly abused in terms of rights. So that's how social justice ministry somehow became the nodal ministry for it. And if we leave aside doctors and psychologists to some extent, other workers there, if they have any qualification, this is the certificate courses by social justice ministry. They give this to any person who would be interested in this treatment and is willing to take a 1 month, 2 month, 3 month kind of a course. So that's where I think the rights approach comes into picture rather than only as a medical disorder.
Yes, Dr. Agar, I want to add that one is that we have to understand addiction treatment is not only a responsibility of the health department, only ours.
Yes.
It's a department of police who has a law enforcement agency that has to curtail the production and selling. Our job is to give the treatment, and social justice, they mainly relate to the awareness program. And I am really uh, glad that Dr. Ambekar sir has started this ATF scheme for India, and there are more than 40 centers right now working in India. And these centers, this ministry is providing free OST treatment, all the disulfiram, anti-craving medicines, free of cost to the patient. So this is a very welcome step by the AIMS New Delhi, Ambedkar sir and Alok Goel sir. And this is a actually needed uh, treatment for our patients to lower in India.
Right.
Thank you. Thank you. I think we have covered all the questions now.
Yeah.
So we
Yes,
can
sir.
start winding up.
Yes.
So we go first to the chairpersons. Dr. Narasimha, your experiences, you're working in the field. So a bit, not a brief
Yeah.
comment, but a longish comment.
Elaborate
I-
comment.
Please.
Elaborate comment.
Yeah. So before I give my comments, I think I would appreciate Raghav for taking us through uh, a comprehensive view of what accessibility and stigma and in integrating this addiction treatment into general hospital setting. I think he has covered starting from with what is the uh, current prevalence patterns and how GH can be a key opportunity. He has also told about what are the advantages of GH. One important thing that he has told is about the opportunistic interventions during the acute state and what are the disadvantages currently in terms of stigma, lack of insurance, also lack of trained healthcare professionals. And he also highlighted about rapidly engaging strategies like motivation interviewing approaches, like he has told about frames approach, and he has also highlighted about non-judgmental, also focusing on autonomy. And before he find it, he also told what are the strategies that people can use to improve in terms of collaboration with physicians, having some of the programs that he has shown, like having in-house AA program, and emphasizing on the fact that there is need for an evidence-based treatment. And finally, he nicely summarized how to establish and also elaborated on the importance of follow-up. So I would like to thank Raghav for taking us for this comprehensive presentation, and also the discussion was very much fruitful. In terms of my understanding, few points which has come up in the discussion. I think one of the things is about the using faith healers. So I think in Jodhpur itself, I think there is a lot of research from AIMS Jodhpur and CIP also in terms of training these faith healers when to identify that there is a problem and when to refer to us. I think CIP has done research on epilepsy, whereas Jodhpur has done a lot of research in terms of non-communicable disease, which includes substance use also. So they have shown that they are a potential players in terms of referral sources. The second thing that has come up during the discussion is about the addiction treatment facility. I think it is under Ministry of Social Justice and Empowerment. So when after the National Drug Use Survey happened, they have identified 125 priority places across the country, and these 125 priority places has been given ATF with all the full support in terms of OST to other treatments. And they also have a, for example, if there is a need for in a particular place, so the ATF can also procure some medicines locally for supporting the treatment. For example, alcohol is a problem and the main ATF is not giving diazepam, so you can procure with local resources that the money that comes. But when there was a state and center kind of a model where 50% was by the state and 50% by the government, so that model did not work. So right now National Drug Use Survey 2 is happening, so it is just in the starting phase. So maybe in National Drug Use Survey 2 we might know what happened to all these prevalence patterns. I think these are some points that has come up in the discussion that I would like to answer. But thanks for the organizing team for calling me, and also thank you, Raghav Shah. It was very nice listening to you, and hope we'll have much more discussions this towards the end of this month when you come for CamCon. Thank you.
Thank you so much. I look forward to it. Thank you so much, Dr. Narasimha.
Thank
I
you.
think
Thank
we
you,
have
sir.
reached
Mahesh, sir.
time.
Yeah.
Yeah, I think we have covered most of the questions, and now I conclude the session. Over to you, Siddiqui sir.
Thank you. Thank you. Over to Tufan, sir, for your comments and thanks, because Amrit is in another meeting.
Uh, I think it's a very useful presentation.
It was an excellent session. Thanks, Dr. Raghav, for a erudite presentation. I shall make a brief comment about the mushrooming of de-addiction centers. Even before Nasamukht Bharat, in most of the places there was a mushrooming of de-addiction centers, rehab centers, by the unqualified people, just because it paid. There are state grants, and if one could manipulate, one could get international grants. And most of the centers I have seen, many of them had the signature of some psychiatrist somewhere who did not visit regularly. This is the fact. Because most of us have been offered that you, sir, shy need to become a. No, this cannot be possible. That is how it operates. It feeds. Why ex-addicts who is financially otherwise ineffective, if this feeds him, he goes for that. And there are people who can encourage him, get funds. It only runs on funds, and it has to spend less, therefore they don't spend for the persons. Then about the paraclinical staff, they are really scarce in our country. And in states like Korea, they're scarcer. Where you'll get them? If we open up the addiction centers in most of the leading general hospitals, there are not so much of psychiatrists. And about the definition, Mental Health Care Act strictly tells that if the psychological disturbance is of substantial intensity, it comes under the purview of MHC. When you tell it is not substantial, it is not. But when it is recorded it is substantial, it comes under purview of MSCA. No excuse. It comes. So these are the, one has to have a more clearer legal sanctions and legal mode of operation, and a bit of laxity to have it in general hospitals. Then it will be possible. Thank you very much, Dr. Raghav Shah. Thank you very much, Dr. Lakshmi Narasimha, for your rich comments, and Dr. Mahesh for your involvement, all the moderators, Amrit in absence, and Tarun Sharma, and last but not the least, all the participants today. Thank you a lot. Good night.
Thank you, sir. Thank you,
Good
everyone.
night.
Dr. Raghav, Dr. Mahesh, Dr. Narasimha. Hope to see you again next week.
Hope to see you.
Thank
Dr.
you.
Narasimha,
Ending the
prepare please
meeting.
something.
Good night.
April.
Good
Yes,
night,
Thank
yes,
you.
sir.
yes.
Sure, sir.
Okay, good night. Good night. Thank you.